Welcome to the deep dive. If you just look around these days, restaurant menus, supermarkets, even just talking to friends, you see so much avoidance. Gluten-free this, dairy-free that, nut-free everything. It feels like our modern diets have gotten incredibly complex and maybe created this huge, frankly quite confusing landscape of food restrictions people put on themselves. We feel a bit off, maybe some stomach trouble, so we start cutting things out. But are we actually getting the diagnosis right when we talk about these adverse reactions to food?
That really is the core question, isn't it? And it's so important because jumping into these diets, these eliminations, without a proper diagnosis, well, it carries real risks. We've looked at the latest clinical guidelines for this deep dive, and the goal is to be some clarity. We're talking about food hypersensitivity. That's the proper umbrella term for any unwanted reaction to food that happens reliably. We really need to cut through the noise, define the terms properly, and map out the reliable ways to get a diagnosis.
Okay, so our mission today is clarity, actionable clarity. We're going to focus on what? Three big insights from the sources, right? Things that might even seem a bit counterintuitive. First, this surprising gap between people feeling like they have an allergy and actually having one confirmed. Second, there's been a huge, total flip in the advice on preventing allergies in babies. We need to cover that. And finally, let's nail down the actual differences between a true allergy and intolerance and something like celiac disease. Sound good?
Sounds perfect. Let's dive in.
Right. So food issues, it feels like they're everywhere. Almost everyone knows someone avoiding something. But how often does that feeling, that self-reported symptom, actually line up with a confirmed medical diagnosis?
Yeah, that's where the data is. Well, it's pretty eye-opening. It highlights this massive diagnostic dilemma. There's a surprisingly poor correlation between what people report, the symptoms they feel, and what the tests actually confirm. There were studies, one from the UK, for example, found that maybe 20% of people said they had some kind of bad reaction to food.
Yeah.
But when they did the proper testing, the gold standard testing, less than 2% actually got a confirmed diagnosis.
Less than 2%. Wow.
Yeah, and another big study, this one was in Germany, put the confirmed rate a little higher, but still only at about 3.6%. So what that tells us is the vast majority of people cutting out foods because they suspect something. They're probably dealing with something else entirely, or maybe nothing specific at all.
Okay, wait. If it's only 2 or 3% getting confirmed, that really flips the script on just deciding to cut out, say, gluten or dairy on your own, doesn't it? The risk versus benefit looks totally different.
It absolutely does.
Yeah.
And that's exactly why we need clear language. Food hypersensitivity, that's the big umbrella term. But underneath that, you've got two main paths. There are the allergic reactions. Those involve the immune system, right? Like the IgE-mediated ones, think classic peanut allergy. And then there are the non-allergic reactions. These don't directly involve the immune system in the same way. We usually call these food intolerances. Lactose intolerance is the classic example.
But the danger is people skip that whole diagnostic step. They just jump to avoidance. And you said eliminating foods isn't harmless. What are the actual downsides, the negative consequences, if you do that without a proper diagnosis?
Well, the list is longer and more serious than most people think. For adults, yeah, you can end up with nutritional gaps. And there's the social side too, right? Getting fixated on food, feeling isolated. For babies, it's even more concerning. Cutting out food groups without reason can lead to poor growth, even malnutrition. It can really stall the process of introducing other healthy foods. But maybe the most surprising risk, the one people really don't expect, is potentially losing tolerance to that food.
Losing tolerance. How does that work? If you could tolerate it before, why would stopping it make things worse?
It seems counterintuitive, I know. But think about it. Your gut's immune system is constantly learning what's safe. If you completely remove a food that your body was actually handling okay, maybe with just some minor vague symptoms, that learning process stops for that food. The gut doesn't get the signal anymore that this protein is okay. So over time, your immune system might actually start to see it as foreign, as dangerous. You could, in theory, create a clinical allergy that wasn't really there before just by avoiding the food unnecessarily.
Huh. So let's say I cut out nuts for a year because I thought maybe they made my stomach feel funny once. When I try them again, I might actually have caused a bigger problem for myself.
It's a potential risk, yes. That's a significant trade-off, especially when, statistically, the initial feeling was a true allergy was pretty low to begin with.
Okay, so just to ground us again, what are the most common allergies when they are properly diagnosed? What's the real prevalence?
When we look at confirmed allergies, the overall rate in Europe is estimated somewhere between 1% and 3% for both kids and adults. Not nearly as high as the self-reported numbers suggest. And the usual suspects, the most common confirmed ones, are things like cow's milk, chicken eggs, tree nuts like almonds, cashews, walnuts, peanuts, fish, shellfish, soy, wheat, and sesame.
All right, so we know self-diagnosis is shaky, very shaky based on those numbers. But okay, someone strongly suspects an allergy, they go to their GP. Usually the first step is asking for tests, right? Blood work, maybe a skin prick test. And this is where things get really interesting because the sources we looked at basically say, hold on, those simple tests alone aren't the answer.
Exactly. And it's crucial to understand what those tests, like the blood test for specific IgE or CIDE, actually tell you. The key takeaway from the guidelines is that just checking CIGE in the blood is not recommended as a standalone diagnostic tool in general practice. Same goes for the skin prick tests.
Well, why not? It feels logical. If you have the antibodies, you must be allergic, right?
But that's the critical point. There's a huge difference between sensitization and clinical allergy. A positive blood test or skin prick test only confirms sensitization. It means your body has created those IgE antibodies against that food protein. But crucially, you can be sensitized and have absolutely zero symptoms when you eat the food. It just shows your immune system has noticed the protein.
So the test shows potential, but not necessarily reality.
Precisely. These tests, used alone, have what we call a low positive predictive value. A positive result doesn't reliably predict that you'll actually have a reaction. Relying only on them leads right back to that unnecessary elimination we were just talking about, with all its downsides.
Okay, that distinction sensitization versus actual clinical allergy, that feels like the missing piece for a lot of people. So if blood tests and skin pricks only show sensitization, what is the definitive proof? What's the gold standard test the specialists use?
The ultimate diagnostic method, the one that gives real certainty, is quite complex. It's called the double-blind placebo-controlled food challenge, often shortened to DBPCFC.
Double-blind placebo-controlled food challenge. Okay, that sounds serious. Why double-blind? Why all the control?
It's absolutely vital for removing bias, both from the patient and the observer, the doctor or nurse. In a DBPCFC, the food allergen is hidden. It might be in a capsule or mixed into another food or liquid. And here's the key. Neither the person getting the food, nor their parent if it's a child, nor the person giving it knows if it contains the real food, the verum, or just an identical-looking placebo.
Ah, so nobody knows what's being given when.
Exactly. And that's essential because so many allergy-like symptoms, a bit of itching, feeling vaguely sick, maybe some mild stomachache, could be subjective. They'd be influenced by anxiety or just expecting to react. The DBPCFC strips all that away. If you react during the verum phase, but not the placebo phase, under controlled conditions, then you know it's the food itself causing a reproducible reaction.
Got it. It rules out the nocebo effect feeling sick just because you think you're getting something bad. That sounds like it needs a special setup.
Oh, absolutely.
Yeah.
It's not something done lightly or in a standard GP office. Because there's always a risk of a severe reaction, even anaphylaxis. The DBPCFC needs highly trained staff, emergency equipment on hand, and it's almost always done in a specialized clinic or hospital setting. It's resource intensive, but it's really the only way to get that diagnostic certainty for many suspected allergies.
Right. And given how rigorous that is, what about managing symptoms if someone with a confirmed allergy does accidentally eat the food? Is keeping antihistamines around the standard advice?
Actually, the guidelines are pretty clear on this now. For managing routine food allergy symptoms, things like oral antihistamines or even chromoglycic acid are generally not recommended anymore. There's just not enough strong evidence showing they're consistently effective for food-triggered reactions.
Really? Not even antihistamines?
Not as a primary management strategy for the allergy itself. Obviously, for severe reactions, anaphylaxis, the advice is immediate use of an adrenaline autoinjector, like an EpiPen. That's life-saving. But for milder ongoing symptoms, avoidance is the main strategy, not relying on regular medication.
Okay, this next part feels like the real game changer, the big aha moment from the sources. Because the advice, especially for babies, has done a complete 180 turn from what my parents were probably told. The old wisdom was always delay, 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 giving potentially allergenic foods like nuts or eggs to infants. What's the thinking now?
It's a massive shift, driven by strong evidence. The new recommendation is basically the opposite. Early and regular introduction of common food allergens seems to be preventative. Specifically, introducing foods like peanut and egg to babies somewhere between 4 and 8 months old appears to significantly reduce their risk of developing allergies to those specific foods later on.
Wow. So we went from hide the peanut butter until they're 3 to give them peanut butter before they're even 1. Why such a drastic slip? What changed?
Well, the research, particularly large studies like the LAE study on peanuts, strongly suggested the old avoidance strategy might have actually been counterproductive. The thinking now is more focused on inducing tolerance through the gut. The digestive system is designed to encounter food proteins and learn they're safe. If you delay introduction too long, or if maybe the first exposure happens through inflamed skin, like with eczema, the immune system might get the wrong signal and develop an allergic response instead of tolerance.
Okay, you mentioned eczema. That brings up the high-risk babies. What's the specific advice for infants who already have conditions like moderate to severe eczema, which often goes hand in hand with allergies?
Right, eczema is a big marker for atopic, that general predisposition to allergic diseases. For those infants considered high risk, often because of existing eczema, the advice is even more proactive. Introduce those high allergy foods, definitely peanut and eggs, starting from 4 months old, but no later than 6 months. And crucially, it shouldn't be a one-off taste. It needs to be followed by regular weekly intake to maintain that exposure and help solidify tolerance.
Regular weekly intake, that's specific. And what about the other common advice, or maybe myth? Does what the mother eats during pregnancy or while breastfeeding make a difference? Should she avoid allergens then?
That's another one the evidence has largely debunked. Following a specific elimination diet during pregnancy or while breastfeeding does not seem to reduce the child's chances of developing a food allergy. The general advice now is for mothers to just eat a normal, balanced diet, unless they have their own diagnosed allergy, of course.
Okay, let's shift gears slightly. If a child does get diagnosed with a food allergy, what's the outlook? Is it always lifelong? Do kids grow out of them?
Thankfully, many children do develop tolerance over time. Allergies to cow's milk and chicken egg, which are very common in infancy, often resolve. Many kids outgrow them within the first few years of life. However, some allergies are typically more persistent. Allergies to peanuts, tree nuts, fish, and shellfish are much more likely to last into adulthood, potentially lifelong. Although interestingly, we are seeing some evidence now that even some of these can resolve in a portion of people later on. And we should definitely mention the atopy link again here. It's this strong connection we see between food allergies, asthma, and eczema. They often cluster together in the same individuals or families. One leading theory, called the dual allergen exposure hypothesis, suggests that for some kids, especially those with eczema, the initial sensitization might happen through the damaged skin barrier. The immune system encounters the food protein via the skin first, which might prime it for an allergic reaction, instead of learning tolerance to the gut when the food is eaten.
So the skin barrier issue could be a starting point for the whole allergic cascade.
Interesting. All right, let's move on to conditions that often get lumped in with allergies, but are actually quite different. First up, celiac disease.
Yes, it's absolutely critical to understand celiac is fundamentally different. It is not an IgE-mediated food allergy. It's a T-cell-mediated autoimmune disease. What that means is the body's own immune system mistakenly attacks itself specifically, the lining of the small intestine when someone with celiac consumes gluten. Gluten is that protein found in wheat, barley, rye, and some oats.
So allergy is the immune system overreacting to something external, like peanut protein. Celiac is the immune system attacking your own gut tissue triggered by gluten. Why is celiac sometimes hard to spot? What does it look like clinically? Well, its presentation can be incredibly varied. Sure, you have the sort of classic gut symptoms, chronic diarrhea, bloating, abdominal pain, sometimes constipation, but very often it shows up with symptoms outside the gut entirely. Things like unexplained iron deficiency anemia, persistent fatigue, failure to thrive or grow properly in children, even neurological issues or problems with bone density like osteopenia or osteoporosis. It's also frequently found alongside other autoimmune conditions such as type 1 diabetes or autoimmune thyroid disease.
Okay, and I think you mentioned earlier there's one absolutely crucial piece of advice for anyone who even suspects they might have celiac before they get tested.
Yes, and this is non-negotiable from a diagnostic perspective. You must continue eating gluten regularly until all the diagnostic testing is complete.
Why is that so important?
Because the main initial tests are blood tests, looking for specific antibodies, like tissue transglutaminase, IgA, TTG-IgA, and checking total IgA levels. If you go on a strict gluten-free diet before these tests, the inflammation in your gut can start to heal, and those antibody levels in your blood can drop, potentially back to normal. This can lead to a false negative test result, meaning the diagnosis is missed. You need the gluten exposure to keep the autoimmune response active for the test to detect it.
Right, so don't stop the gluten until the doctor says so, essentially. Got it. Okay, let's switch to the non-allergic, non-autoimmune side. Lactose intolerance, probably the most common issue people self-diagnose.
Yeah, and this one is much more straightforward mechanistically. It's not an immune reaction at all. It's simply caused by having insufficient levels of an enzyme called lactase in your small intestine. Lactase is needed to break down lactose, the sugar found in milk and dairy products. If you don't have enough lactase, the lactose passes undigested into the large intestine, where bacteria ferment it, producing gas, bloating, cramps, and often diarrhea. That's lactose malabsorption leading to intolerance symptoms.
And what's really interesting from the sources is that for most adults globally, having lower lactase levels is actually the norm, isn't it?
That's exactly right. Primary lactase deficiency, meaning your body naturally starts producing less lactase after infancy or early childhood, is considered the ancestral or sort of normal state for the majority of the world's adult population, particularly those not of Northwest European descent. It's actually quite rare for this primary deficiency to cause symptoms before the age of about 5. The ability to digest lactose well into adulthood is more of a genetic adaptation found predominantly in populations with a long history of dairy farming.
So for many adults struggling with a big glass of milk, it's not really a disease state, it's just normal human biology.
In many cases, yes. Management isn't about curing anything, it's just about finding your individual tolerance level. This usually means limiting lactose intake to what you can handle without symptoms. Maybe that's only small amounts of milk, or maybe up to 1 glass a day is fine for some adults. Spreading intake through the day can help too. Choosing dairy products where the lactose is already partially broken down, like aged hard cheeses, yogurt, or quark, is often better tolerated. And of course, there are over-the-counter lactase enzyme supplements you can take with dairy-containing meals.
Okay. And finally, there's this kind of gray area condition mentioned, non-celiac gluten sensitivity, sometimes called NCGS. What exactly is that?
Yeah, NCGS is a bit trickier because it's largely defined by what it isn't. It describes people who have reproducible gut symptoms similar to IBS maybe, like bloating, pain, changes in bowel habits that clearly get better when they avoid gluten-containing grains. But they've already tested negative for both celiac disease and wheat allergy.
So celiac and allergy are ruled out, but avoiding gluten still helps them feel better.
Exactly. But the meaning, the underlying mechanism, even the precise trigger, it's still not fully clear. Is it definitely the gluten protein itself causing the issue? Or could it be other components often found in gluten-containing grains? Things like fructans, which are a type of FODMP, those fermentable carbohydrates that can cause gut symptoms in sensitive people. It's an area where more research is definitely needed to understand what's really going on. #ATREGATRO.
Wow, okay, so wrapping this up, this deep dive really underscores the need to move from just suspecting food issues to getting solid scientific answers. The big takeaways for me are, first, that actual confirmed food allergy is way less common than we might think based on self-reports. And second, jumping into elimination diets without proof carries real risks, like actually losing tolerance to a food.
Absolutely. And we saw that the gold standard for diagnosis, that DBPCFC, while complex, is sometimes necessary for real certainty. Plus, that massive shift in prevention advice for babies, early and regular introduction of foods like peanut and egg, starting between 4 and 8 months, is now seen as protective, not harmful.
So thinking about the listener trying to navigate all this, trying to figure out their own health or their family's health, what's the final thought to leave them with?
I think it comes back to that concept of asymptomatic sensitization. Remember, just finding IgE antibodies on a blood test doesn't automatically mean you have a clinical allergy. It's actually quite common to be sensitized but have no symptoms at all. And here's the provocative idea to mull over. If you take that asymptomatic sensitization, that harmless positive test, and then you decide to strictly eliminate the food based only on that test, you might be interfering with your body's natural state of tolerance. You could potentially turn something that was harmless into an actual problem. You risk inducing a clinical allergy where none truly existed before. So the bottom line really is, before you make drastic changes to your diet, especially cutting out major food groups, please seek proper expert medical advice and diagnosis. That certainty is key. It protects your health, your nutrition, and honestly, your quality of life.